morning, everyone, and it's my pleasure to present a quick summary on behalf of my co-investigators and colleagues regarding our work with mezigdomide combined with dexamethasone and monoclonal antibody therapy for patients with relapsed and refractory myeloma. And these are preliminary results from the CC92480-002 trial, which we presented at this last year's December American Society of Hematology in San Diego. By way of introduction, mezigdomide, which we formerly called 92480, is a novel, potent oral cereblon E3 ligase inhibitor, which is a so-called CELMoD. And this has profoundly enhanced tumoricidal and immune modulatory effects. And these are actually in a different class, I would propose, than the original so-called immunomodulatory drugs, or IMiDs. And in fact, molecularly, as a chemical structure, they are quite distinct. But they obviously target the same thing, which is the cereblon E3 ligase complex, but do so in a much more profound and established way. In other words, this binding into this pocket, which you can see here in green, is that much more complete compared to, say, for example, pomalidomide, which is an IMiD, and obviously engages the same broad target, but does so quite differently. And this is reflected by the fact that if you look at how much closure there is of the cereblon E3 ligase complex, with mezigdomide, this is a striking 100%, versus just 20% for pomalidomide. Now, why does this matter? Because this has a profound effect on how this target then modulates anti-myeloma effects. Specifically, if you close this pocket as profoundly as mezigdomide does, you can see here that there's dramatic killing of myeloma cells in preclinical models compared to pomalidomide at the same concentration at the bottom. Well, in fact, actually at a higher concentration than the mezigdomide, but nonetheless at a concentration that we see in patients. And the bottom line is mezigdomide at a concentration that we also see in patients, but at much lower micromolar dosing, is incredibly active. And when you combine mezigdomide with monoclonal antibodies in preclinical systems, the effects appear synergistic. So with that in mind, the study design that we used for combining MEZI, as we affectionately call mezigdomide, with a variety of new drugs is summarized here. And that basically, as you can see, we not only looked at daratumumab and elotuzumab, but we also looked at bortezomib and carfilzomib, which we reported on previously. Now, I would just simply say for today's discussion, we're going to focus on the daratumumab experience and elotuzumab. And the objectives were to establish, could this be safely combined on the one hand? And very importantly, was this active? So what did the results show? Well, first and foremost, this shows you the various schedules. And to really get to the chase here, we looked at a variety of different schedules for the daratumumab mezigdomide combination, just to optimize dose and schedule. And we looked at a classical schedule for elotuzumab, 3 weeks on and 1 week off. And importantly, we looked at 2 different doses of mezigdomide, either 0.3 or 0.6. And what we found, which was so interesting, is if you look at, for example, in the DARA population of patients, the DARA-exposed cohort, we had a very significant triple-class refractory high-risk group here compared to the elotuzumab group, in whom more of them had had prior CD38 exposure. If you look at the refractory status, as I mentioned, most of these patients were refractory to available therapies. And importantly, in the ELO group, at least a third were what we call triple-class refractory. But I think the most important takeaway from this is all patients had received prior IMiDs and proteasome inhibitors, and most of those patients in the elotuzumab cohort were actually CD38 refractory. Now, in terms of duration of treatment, it's important to share that the B1 group were the most mature in terms of the number of cycles received. And at the same time, the B2 and B3 groups had less exposure, but nonetheless something we could certainly report on. And in the 20 patients who participated in the elotuzumab cohort, we had a decent exposure, but the most important point is very few patients had discontinued due to adverse events. Now, the real sort of core of the presentation was here in terms of the side effect profile, which basically shares with you that the side effect profile when you combine mezigdomide with daratumumab. And as mentioned, we looked at 2 doses, 0.3 and 0.6 milligrams, you can see here that the side effect profile was remarkably good. And then when we looked at the actual specifics of the side effect profile, neutropenia was the dominant effect. And as I mentioned, we saw this at both 0.3 and 0.6 milligrams given according to the respective schedules. One was 3 weeks on and 1 week off. The other was 2 weeks of every 3 weeks. And the other one was syncopated, where we gave 7 days on with 7 days off and then repeated this. And the goal here was really to establish what the best and safest dose and schedule was. And we were very pleased to see that neutropenia was our dominant side effect, but again, generally very manageable. Now, in the context of efficacy, these are summarized here. As you can see, for the whole group of patients, and remember, these are relapsed refractory patients, and although they were not refractory to CD38, obviously, which was key, importantly, obviously, therefore, we would expect them to be responsive to CD38 targeting. But nonetheless, what we were very pleased to see was the obvious synergy by combining the mezigdomide with the daratumumab. And what you can see here is that in the most mature cohort, so-called cohort B1, the response rate was 83%. Remarkably, in cohort B3, it was approaching 90%. And in this less mature group, who were on the schedule that was 14 days on, 1 week off, it was 61%. But that's probably a function of time on treatment as opposed to anything else. And what was really interesting was if you look at the group overall, about 80% of patients responded, which is, again, supportive of synergy. We would expect mezigdomide alone to generate a response rate of around 40% and would expect daratumumab alone to generate a response rate around 30%. So to see this 80 to 90% response rate was really very encouraging. And I think the real proof of the efficacy of this combination lies in the so-called median durations of response. As you can see, it has not been reached in terms of cohort B1 or B2 for that matter. But if you look at the lower boundary, it's 23 months for the lower boundary of duration of response for cohort B1, which is, I think, very encouraging. And most importantly, if you look at the swimmer's plots, which are here, you can see how well some of the patients on B1 are doing, even at the 0.3 milligram dosing compared to 0.6. And what you can see here is that we have patients as far out as 41 and now 42, 43, and 44 cycles into this experience with the combination. And if one thinks of that as a monthly cycle, we're now in the space of 3.5 to 4 years. So this is, I think, very encouraging. And at the same token, if we look at elotuzumab, we see here, again, very well tolerated, generally speaking. And very importantly, just as we saw with daratumumab-based therapy, no COVID-related mortality. And then excitingly, manageable toxicity profile with neutropenia is the issue, but again, treatable. And in this group of patients, the response rate was a little lower, 45%. And this obviously reflects the fact that the majority, almost all of these patients, were CD38 antibody refractory. And on the other hand, I think it also reflects the fact that elotuzumab isn't perhaps as powerful an antibody as daratumumab. But that being said, to see in the daratumumab exposed and or refractory population, a response rate of around 45% for us was encouraging and certainly points to this as being a viable option. Now, what about the effects in terms of the pharmacokinetics and pharmacodynamics of the treatment? And remembering this treatment, mezigdomide, is designed to modulate T cell and NK cell responses. We affectionately think of MEZI as CAR T in a pill, if you will, although I think that's a little bit simplistic, but nonetheless, it's a nice way of thinking about it because it does modulate T cells and natural killer cells. And what we're pleased to see is that mezigdomide was pharmacodynamically active in T and NK cells at all 3 schedules and at both doses that we tested. And very importantly, there were some schedule-dependent T cell effects, which suggested this drug really is influencing the behavior of T cells. And then when we looked at the same platform in the elotuzumab patients, we showed that mezigdomide combined with elo was actually very active in both the T cell and NK cell compartment with elotuzumab as well. So this was a very consistent signal. So what are our conclusions? Well, this is the first analysis of mezigdomide combined with monoclonal antibodies, and it shows promising efficacy. Obviously, with the Mezigdomide combined with the daratumumab, we have an overall response rate of around 80%, and in one cohort, it's approaching 90%. With elotuzumab, recognizing that they're a more refractory population and the vast majority of patients were so-called CD38 refractory, we saw a response rate of around 45%. So in the context of a well-tolerated therapy, definitely something worth watching. Nonetheless, the impact in the daratumumab cohort was particularly striking, with durations of response that appear really very long, approaching 4 years for some of the lead patients. So I think what's also terribly important to appreciate is the immune stimulatory effect of mezigdomide. And this, I think, builds a very exciting rationale for combining mezigdomide with our best immune therapies. This would include, obviously, BCMA targeting and GPRC5D approaches in the setting of not only bispecific T-cell engagers, but also, very importantly, CAR T therapy. So a really exciting therapeutic adjunct in the making, in my opinion. And I want to just close by really acknowledging, above all, our patients and families who participated in the trial, our clinical research teams at each of the respective sites, our pharma partner in this very important work, BMS Celgene, and then particularly the co-investigators that I've listed here, literally from both Europe and the United States. And thank you very much for your kind attention.